Hello, thank you so much for joining us today. I'm Dr. Chad Versio, the Chair of Pediatrics at Riverside University Health System, and we're really excited to share with you some of RUHS's lean journey. There's obviously a lot of different departments where lean has been deployed, and we heard a little bit last week about how lean has been used in the quality sphere. This month, we are going to hear from Dr. Mahbuba Khan, who's over the operations of the community health centers for RUHS. And so really excited to kind of hear how she has internalized lean and implemented it across the community health centers. We are likely to pivot back towards medical center related activities next month, and we'll probably be looking at the limb salvage program. And so please tune in next month for that. All right, I'll turn it over to you, Dr. Khan, so you can kind of tell us about RUHS's CHC lean transformation journey.
Sure, Dr. Versio, thank you so much. Some of you who don't know me, I'm Mahbuba Khan. I'm a family physician by training. I was trained in RUHS. I serve as the medical director of operation for our community health center clinics. I have my partners here with me, Patricia, Baptista. If you can turn on your camera, I want to introduce Patricia. She's our lean consultant. Patricia, you want to introduce yourself quickly to the group?
Hi. Yes, I work for Simpler Consulting, which is an external consulting group that obviously has worked with IHP and is now working with Riverside University Health Systems. I'm a nurse by training and pretty much have done this for the last 20 years in consulting with healthcare clients. So it's been a privilege to work with Dr. Khan and the team, and they've done some great work, as I'm sure you'll hear.
Awesome, thank you. Just wanted to add one more thing about Patricia. Patricia came from Virginia Mason. As you all know, Virginia Mason is one of the leading healthcare organizations on lean spread. So thank you, Patricia. I also want to introduce Siale Lutu. Siale, are you on the call? If you please turn on your camera and introduce yourself. Siale.
Hello,
Okay.
Can you hear me?
Yes.
Yes.
Okay.
Go ahead. Mm-hmm. Go ahead, Siale, if you want to introduce yourself. Hi. Go ahead.
Okay. Hi, everyone. Sorry, I had to switch to being a panelist. Hi, my name is Siale Lutu. I'm from IEHP, and I've also been helping out with the lean transformation journey with RUHS. We've been partnering with RUHS for quite a while now, and then we really got into the weeds early last year. So it's been a fun journey to ride along.
Thank you, Siale. So I'll start our presentation here.
Dr. Khan, it looked like you muted.
Yeah.
Okay, thank you.
Sorry. Okay, next page, Leslie. Thank you. Lean transformation is a journey, as all you know. This journey has no destination. Developing a lean organization requires a long-term view. Next page. The reason we went to this journey was we did have lean training a couple of years ago. It was 2 days of educational training given to our providers and our team. But what was missing was a coaching component afterwards on how to implement and engage our staff was not available afterwards. So during our 2 years ago, when we started rounding with our executive consultant, Dr. Flowers, Dr. Gilbert, it was obvious that our team needed some hands-on training on how we can effectively problem solve and engage our frontline teams. We had a process of communication, but it was not consistent across the board. Our team felt they were unheard, not part of the changes happening in the clinic. Organizational goals were not clear to the frontline teams. And then, of course, with pandemic, our priorities kind of shifted, caused more stress to our team and leadership team. Next page. So when Dr. Flowers and Dr. Gilbert kind of helped us with that, they kind of connected us with IEHP and our executive leadership and IEHP. And then when Tricia comes along as a lean consultant from Simpler and Siale to help us looking into a lean transformation journey. And this partnership, we aimed for development and implementing a strong lean management methodology in all 13 community health centers in next 3 to 5 years that will ultimately support the achievement of RUHS goals, access, and service excellence to the patient we serve. Next page. So our formal journey started on June 2020. We kind of looked at, where we start first, and we thought about, okay, we need to standardize our huddle board because this is where our messaging flows both upwards and downwards to the frontline team and upwards towards our executive suite. So that's where we started our journey. Next slide. So first wave was all about implementing MDI huddle. So MDI stands for Managing for Daily Improvement, which is developing standard huddle format for all 13 community health centers. Again, this is all about bringing our team on action. So we started this pilot in 3 sites, Lake Elsinore, Paris, and pediatric clinic on MSC, 3rd floor. With also key administrative leaders who were part of this design on the huddle. It was 6 to 8 weeks of intense coaching by our consultants. The leaders learn not only how to run a 10-minute daily huddle, but also how to engage staff in identifying issues and engaging the staff to own and to be part of problem solving. The leaders learned to become curious, began to learn how to ask questions rather than how to provide solutions. We also learned how to encourage and recognize our team members who are getting involved in improving the delivery of care. The administrative leaders were also expected to attend huddles, observe and coach during their rounding. Since June 2020, rounding and attending huddles is part of our regular schedule now. Next slide. So this is how the picture of a huddle board. You can see this is a huddle board of family care clinic on the 3rd floor of MSC, and what is the huddle board structure would look like. So the MDI board consists of 2 portions. It's the daily readiness portion and organizational metrics portion. The daily readiness portion supports the focus of what is working today. And organizational metrics is where we want it to be our long-term goal. Next slide. So our first step was to make sure our team feels comfortable getting the daily readiness huddle board up and running. So we kind of start working with the teams are we ready for today? What is our productivity goal? Do we have staffing to support our goals? Is there any opportunity to provide access? Are we confident that we're going to meet the goal? The board also, the board should be transparent and visible to all to make sure that they understand where we are, what is our current state. We use green and red color to identify area where we are doing great, identify area where we have opportunities. In addition to productivity and access, the daily readiness portion of the board also works for call-out issues, opportunities for any standard methods, supplies, equipment, staffing, which we call mess board. This is where it gives opportunity to the staff to identify and provide a potential solution to things that might cause disruption for the day. We also bring safety team on the board, escalations, recognitions, and announcement. And then the organizational metrics is all about our what we want to aim for, our long-term goals. So our clinic leaders meet with our quality team based on our performance improvement round. We choose organizational metrics that we have opportunity to improve upon. It has to be quality metrics, service metrics, and an access metrics. The team go over the metrics and they assign a champion for each metrics, who kind of leads the PDSA for each metrics and report out weekly basis. Next slide. Again, this shows the principles of MDI, which I just shared. Next slide. Again, MDI is about repetitive process designed to connect, everyone to what is important. It helps leaders in all levels to spot normal from abnormal. It makes team to be proactive rather than reactive. It helps to develop servant leaders and coaches. the most importantly, team-driven problem solving. Next slide. Example of standard huddle board and huddle. And so you can see this is Lake Elsinore Huddle Board. Lake Elsinore is our first clinic who implemented Huddle Board. They are on their next level of huddles where they have their team runs the huddle now. So a very, very accomplished team there. Next slide. DMS huddles are part of our daily routine now. It is happening across all CHCs in different levels. We start our day at 7 o'clock with a virtual huddle with all clinic leadership, our admin, every single day, Monday to Thursday. It's a 15 minutes intense, structured, tiered, and timed huddle. We have days that we have themes. For example, Monday we do quality. On a Thursday we do escalations, kudos. The speakers are taught and instructed to be very specific on their content sharing, making the content understandable, either it's an informational or action-oriented. Our managers and PICs, physician in charge, they started to rotate now and lead our huddle. It happened all across all CHC leadership. They joined that huddle every day. So this is our 7 o'clock huddle where the huddle, the information flows to the clinic, and it also gives us opportunity to escalate and information flows up to the executive suite. Then the clinic does their 10-minute huddle across the board in all clinics, which is facilitated by their management team and their staff. We also do an 11 o'clock access huddle with our scheduling team to ensure that we meet our access demand for our patients and supplies for the clinic. And then our operation team does meet weekly basis to ensure that they're supporting each other and on the same page. So you can see how the communication flowing in different levels. It really, we really noticed that it improved the communication challenge that we had 2 years ago. Next slide. The second wave of our lean journey was learning about rapid improvement event. Our first event was on June 2021. It was about developing a standard rooming and discharge process for adult primary care visit. The RIE occurred in 2 clinics, Lake Elsinore and Paris Valley. It involved, it was a multidisciplinary team. So the rapid improvement events are highly facilitated intense sessions that bring a team together, usually 5 to 9 individuals who work within the process along with the representative from upstream, which is our suppliers, and downstream, our customers. Our focus is on eliminating waste. There's a timeline that we have to follow. I'd start with the selection of a multidisciplinary team. There's some pre-work before the actual event, then actual event, which is 4 days intense sessions, and then testing. Whatever we develop from the event, then we test again for a couple of weeks. And then once we have the final product that is hardwired and weighted by this team, we do implementation and sustainment. Next slide. Awesome. Here you can see the different waste that we learned during this rooming and discharging RIE. There are 8 most common waste that we see in healthcare. It's defect, overproduction, waiting, non-utilized talents, transportation, inventory, motion, and extra processing. I just want to bring an example of a motion waste that we found out on our RIE. It was about LVN and printing AVS, which is after visit summary. So our LVN, our nurses, they have to print AVS and then give it to patients during each discharge process. So what we found out in Lake Elsinore Clinic, the printer was far from the LVN desk. So every time she's discharging a patient, she has to go back, get her printed copies, and then go back to the patient exam room and give it to patient. So she has to do it 23 times in a day. And that we looked at it, took a good amount of her time going back and forth to get that printed copy and then going back to the exam room. So we're able to eliminate this waste just moving the printer close to her desk. Next slide. Thank you. This is a picture of Dr. Gilbert going over why the standard work is key, why it is important to produce consistent, reliable, and predictable result. This is our second way also to learn about standard work. Next slide. The standard work created by the people who does the work, not necessarily a consensus. It is a group that works from what is best practice and start from there, create and document completely new process, and then with the help of their peers. The standard work should work 80% of our time. If it's not working 80% of the time, then we have to relook our work. The 20% of time when it doesn't work, we use our judgment and creativity. Especially when we are busy, we have to rely on our standard work because it ensures predictability, safety, and quality. It is foundation for continuous improvement. Next slide. As you're all aware of benefits of standard work, again, it's not just about efficiency, it is about embedding quality, service, and safety in our process. I want to bring two things here. One, I want to emphasize about shifts blame from a person to a process, which is so important. In different settings, we found out that if something doesn't work, we tend to point out the person. Again, Lean taught us it's not about the person, it's about the process. We need to ensure that we have a process in place that make that person successful. Reduce workplace stress, another big thing, right? About having a standard work. For example, if a surgeon nicked a blood vessel or a patient hemorrhaging, in these scenarios, surgeon can trust that there is a process in place for collecting and delivering bloods in a time specific manner, right? In a timely manner. This reduces the stress of worrying about whether he or she will get the blood or not. But at least if his standard work is out there, they know for sure that it will arrive them in timely manner. Next slide. Thank you. The implementation and sustainment phase of any RIEs is the hardest part because then you have to literally go each single clinic, each single staff to ensure that they learn the process and they're consistent. The key of any process change is discipline to ensure sustainment and spread of standard work is there. So we spent 90 days after post-RIE to train and coach these 2 clinics. The team had done multiple tweaks and revision on the standard work to ensure what they see is there. The training of the standard work also required active involvement of leaders, the frontline champions, where each employee received an elbow-to-elbow support and coaching. We also had skill metrics in place to ensure that gives us transparency, who had got the training, who did not, to ensure the managers are able to follow through. Each auditing opportunity allows leaders to coach the staff performing the process and why each step is important performing the process, right? For example, one key piece of standard rooming piece is repeat blood pressure check. So anytime patient comes with elevated blood pressure, the MA has to repeat the blood pressure. If the MA don't know why they're repeating the blood pressure, it will be very difficult to get this consistent work from them, right? So we need to really make sure they understand why the repeat blood pressure is important quality piece. So once they do it, once they understand, they're more likely be consistent on their work. The process of auditing never stops. It becomes part of the leader's standard work. So each clinic manager need to ensure that all their team understand each sections of the standard work and they follow that. We also learn about annual reviews is so important. The annual reviews of all standard work, policy, and procedure should be there in our system to ensure that the standard work remains relevant to our team and opportunities for improvement based on the feedback that we utilize. Next slide. The outcome of our first RIE, we got in standard rooming and discharge workflow, and we did implement it in all our clinics, and training continues our auditing and training to our team members. Our quality process, care gaps, service metrics, they're all embedded on that standard work. We have less paper and more digital documentation now. We have better care team communications, and each team members are clear on their roles and responsibilities, and they're accountable to ensure the quality of patient care and increase trust within each provider teams there. Next slide. Then we started our second RIE, which was January this year, completely a different topic. It was about in-basket management. Our first RIE was learning about standard work. This time we learned more about A3 thinking and how we can use the A3 thinking to develop a new process. We did this RIE in Riverside Neighborhood Clinic. You can see the team is there. Of course, we had a multidisciplinary team there. Starts with our frontline team. We had 2 providers, Epic, Quality, our operational team, and an IHP member was there. Sorry, IHP leader was there. Next slide. So A2 thinking, something new we learned this time. This is the picture showing us a T-shirt folding exercise. Doing this exercise, we learned that it's not about getting things efficiently, it's also about quality. We need to provide an efficient, quality product in efficient timeline. So we learned about A3, how the A3 can work in different problem solvings. I start with what problem we are trying to solve. Do we have the right team member in the team to solve that problem? What is the current state of the problem? We have to look into data, review the data to show the current state. Then we have to set the achievable target and understand and prioritize the gaps with root cause analysis, prioritize all potential solutions, then experiment the solution. Do they work, or they need tweaks, or we need new targets? Then we come up with a completion plan. And after the completion plan, then the sustainment starts. And then each RIE, we learn something. And then our take-home message and how we can use for the next RIE that we learned. Next slide. Just an example of process flow. You have 2 flow there. One is a current state, and the second one is future state. And we ask our team, which steps do you think added value, or which state is necessary, which steps we can eliminate, and our future state, how we can make our future state more efficient. Next slide. A picture of Dr. Ernesto Campos here. He is one of the senior medical director of IHP. This is where IHP's partnership plays an important role. We believe that this is a unique opportunity for RUHS and IHP. This opportunity supports across continuum of care. As this relationship continues, it will certainly provide a case study and opportunity for healthcare providers and peers to explore future collaborations. Next slide. The outcome of RIE2, we improved our turnaround time on results, refills, and message completions by the provider. There's clear roles and responsibilities within care team. So it's not always have to be the provider. Their team, their MA, LVN can also take some load from them and help them to get it done in timely manner. We learned about EHR and how we can optimize EHR tools to support our care team, and also provide a coverage plan. So each clinic, they have providers, they have buddy system, but this RIE kind of helps us how we can structure that. So if a provider is off on vacation on leave, how the coverage should work, not just for provider, also for the staff. Next slide. Third wave, where we are now in our journey, is learning about leader standard work, another fun activity there. So each managers and our admin leaders now working on their standard work. Leader standard work is all about responsibility and accountability built into practice of daily, weekly, monthly checks of the actual condition in the DAMPA. Less variability, make it more predictable outcome. Next slide. This is where the difference, this is where it shows the difference of doing lean and being lean, right? As a lean leader, we have to see how much time we spend on daily management and how much time we spend on strategy development, which is our future goal, right? So it's about running the business, also improving the business. Next slide. Yeah, so leading differently, right? Which lean transformation journey about. So you can see on the top part is a daily operation taking a most part of the leader's time, and strategic activity is very small. This is where some of us feel like sometimes we feel like, okay, we are just working reactively. We don't have time to think. We don't have to set goals for ourselves. But the lean with leadership standard work, we can develop our own calendar where we wanted to spend we can balance it out to, that we can spend a good amount of time on daily operation, day-to-day needs, and then good amount of time of strategic activity, continuous improvement, and innovations and breakthrough events. Next slide. Yes, leader standard work is all about, bottom up. We want to be a servant leader. We wanted to engage our frontline team and learn from them and take it up to the executive team. Next slide. Yeah, we need to constantly ask ourselves as a leader, am I adding value to my team? This board shows chief operating officers leader standard work. You can see a lot of greens, a lot of red there. So we constantly have to ask ourselves, are we adding value to our team? If not, what we can do to add value and how we can support our team. Next slide. This is my favorite part. Through this 2 years of Lean journey, I really enjoy doing Gemba, and I was taught, how to do it effectively, how I can be a good listener, how I can be a good observant, and how I can coach my team every single time I'm going out there, looking for opportunities, helping them so they can see those opportunities and problem solve. I think I spend almost 20 to 30% of my time doing this Gemba and doing this regular rounding now. Hopefully I can do more next couple of years. Next slide. So what is the difference that Lean journey brought up, right? So there you can see on the top part, you can see the clinic volume. So before we started Lean journey, we were seeing community health centers, we're seeing on an average 14,000 to 15,000 patients per month. Since we started the Lean journey, we are currently seeing close to 25,000 visits per month across all community health centers. The bottom part is about unique lives. So fiscal year 1920, which is July 2019 to June 2020, before we started Lean, we saw 65,000 unique patients. Since we started Lean, which was June 2020, you can see we saw 7,000 additional patients on last fiscal year. Our current fiscal year, 21-22, this graph shows how many patients we saw from July to December. You can see we are 57,000. We are projected to see over 80,000 during this fiscal year. So you can see it really helped us to develop efficiency in our system and provide access. Next slide. Again, what Lean journey brought up too is before we started this, we used to see 1.6 patients per hour. With our journey with efficiency, we are currently seeing 2.2 patients per hour. Next slide. We're also looking at our quality measures, which is our long-term goal, how we can improve our quality measures across the board. So UDS dashboard, as you all know, as a federally qualified health centers, we are required to meet national benchmark, national goals. This is where all our quality metrics come into play. And we are hoping with our Lean journey, we can move some of these reds to green and stay and sustain. Next slide. Again, example, dashboard of our UDS metrics. Next slide. This is a testimonial from one of our manager, Riverside neighborhood manager, Cecilia Curiel. I'll just read it through for you all. My Lean journey has been an eye-opening. The skills that I learned is something I can use in my professional and personal life. I have learned to empower my staff to feel comfortable making decisions, taking on project and task. Since we began the daily readiness and metrics huddle standard work, staff have taken ownership and lead huddle every day. They are beginning to see the importance of situational awareness, mass, and organizational metrics. It has been a learning curve for all of them, but they see the importance of reviewing each area daily. They know what will be discussed and are prepped to participate in huddle. As a manager, I enjoy coaching my team, providing feedback and assisting to help them understand the Lean concept. Recently, I observed several areas where I find myself asking my staff, how can I improve? How can we improve in this area? By doing this, I learned that I'm making them part of the solution, not fixing it myself. One key area I have taken from this journey is that a performance improvement plan allows me to take a good hard look at current standards and assess which standard and expectation should be improved upon. Understanding current state of a problem is not a bad thing. Knowing what is the future state will look like makes me feel hopeful. Next slide. Okay, what are our next step in our journey? Again, we are still working on what will be our approach for next 3 to 5 years, but we want to continue our refinement, our MDI huddles and tiered huddle approach. We'll continue learning and developing our UHS leader standard work and personal development plans for our leaders. We'll continue our ongoing development and implementation of process audit methodology. We'll continue coaching of leaders as servant leaders who develop people and team in understanding and implementation of the lean performance improvement mindset. We'll continue development strategic plan, aligning our clinic strategy with overall RUHS strategy. Prioritizing and deployment on lean value-based value stream methodology for a breakthrough transformational change. Most importantly, I think what I started with is lean journey is all about cultural transformation. We want all our clinic staff and providers become contributing problem solvers and adopt the performance improvement mindset. With that, I will conclude my presentation, and now I will open the floor for questions.
Thank you, Dr. Khan. So yeah, if any of you that are attending today want to, put a question in, you have that at the bottom of your screen on the bottom right of the buttons. And we'd love to hear questions from those of you that are participating or attending you may not be working in a clinic setting, but in the inpatient setting and trying to think of how to implement lean in your setting. So please feel free to put those questions in. I did want to ask a question, Dr. Khan. Obviously lean represents change for the organization, and often there is some degree of resistance to change. So what kind of resistance did you encounter, or maybe people that you worked with encountered, and how did you handle that resistance? So that's my first question. Okay, I'll take the first step, and Patricia and Siale, you work with our team too, so please chime in. So from me, the most common one is we don't have time to do this, right? And asking back, the staff member, where you see the challenge, and do you see that improving this process will help the work that you do every day? Asking those questions back to them, I found that it was very helpful to see where they're coming from and how they process those questions. And they're saying, I know if you do this, it may help me to do this. And then we also shared that it is not easy to do something new. It will be hard in the beginning, but at the end, you will not have to go back and walk around that process if you have a standard process in place. But Siale, Patricia, please chime in. You guys also saw the similar kind of issues with our staffing. Mm-hmm.
Yeah, definitely. If I can chime in, this is Siale Lutu from IHP again. Yeah, that's a normal thing that we see even here at companies that have kind of been through the grinder of years with their lean journey. You're still going to see that repeat in resistance for the culture. And I think it's just important to constantly remind teams of the originations of lean, right? It came about during times where, Toyota was firefighting, their backs were against the wall. So they really needed resources allocated to their normal daily operations. But as Dr. Khan just mentioned through some of her slides there, it's really important that we take that time towards, making sure leaders are dedicating time towards continuous improvement, strategy, innovation, building that into their schedules. So same thing with frontline staff.
Thank you.
I'll just add that, change management has its own whole methodology of how to implement change management. And so we use a lot of the change management techniques as we teach lean, and part of that is, finding the early adopters and developing champions and encouraging the frontline person to bring along their peers with the changes that are being implemented in. But I truly believe the biggest piece of breaking down resistance is the management interest in the employee's work. If they're there on the clinic floor asking questions and saying, tell me why this doesn't work, or tell me why this is so hard for you, or what would be better, because I really care about you as a employee and a person working here. If you can do something better, then we know our patients will get what they need. And honestly, all of the people that work at Riverside University Health System, clinic or not, I'm sure comes to work to do a good job. And it's just the convoluted systems that we have in place that prevents them from doing that. And so I say, do you want to go home feeling like you've accomplished something today and really done what you came to work to do? And every one of them say yes. It's just that it's so hard to do it. So getting them involved and leadership standing there beside them, really showing genuine caring about changing the process to make it better for them and the patients, really breaks down those resistance to change. And I always say, it's not working now, so why not try something different, you know? So I think it's a good team, and I think no matter where you go, as Siale says, no matter what client I go to, there's resistance, but you get in there, roll up your sleeves with them, and they immediately say, yeah, let's make this work. And obviously the accountability and discipline of management after everything is very important, because if you just walk away and say, okay, now go do it, they're going to say, well, yeah, you just want us to, you know, do what you want us to do, and you don't really care. So that caring and sharing and rolling up the sleeves is so important.
Thank you. All right, well, we're over time. You know, one of the slides that I really appreciated was the servant leader slide, which showed that, you know, the boss should be developing into the people, and obviously those people are funneling up things to them. And in that entire process in these huddles, the boss needs to be developing, you know, the skills of the people below them. So thank you so much for sharing with us. The CHC Learn Journey is, again, as I said, we likely will be covering the loom salvage program next month. And so look forward to learning about that with you. Thank you very much. Have a good day.
Bye.
Thanks, everyone.